Today I'm going to start off by demonstrating to you all how to do an assessment, a postpartum assessment and a newborn assessment. You are going to be expected to do an assessment on somebody else and video that, and then upload the link so that your clinical faculty can take a look at it and make sure that you know what you're doing. Now, this is not a health assessment video. This is not something that you have to know 100% and have memorized. This is just so that you have some experience and you can get it in your head, the order in which you might do things. And so to that end, you can use some aids to help you. In normal times, when you guys actually come in and do these assessments for us during a checkoff, we always tell you that you can have some note cards. These are my note cards. Okay, yours can look like this or they can look a little bit different. But take the checkoff sheet, the one for postpartum and the one for the baby, and write out in order what you would do on a card so that you have something to refer to. And then when you're done with your assessment, you can look at it and say, oh, I forgot to do bowel sounds. I would have done that before I palpated the abdomen. Or, oh, I forgot to ask her about activity, okay? So this is a reference for you. So again, hopefully this makes you feel a little bit more comfortable that you do not have to memorize it all. Now the postpartum assessment is pretty easy, but the newborn assessment is a little bit more detailed, and so you may need your cards there as well, okay? Okay, I believe we're ready to get started. I'm gonna put my card right here. Noelle is going to be my patient. She's turned on, so her eyes are open. Our beautiful Noelle O'Malley, but she's probably not going to respond to me. So I'm just going to pretend that she's responding to me. And I realize that as you're doing your videos at home, that you may have somebody that can be your patient, and you may not have somebody that can be your patient. And so if you really don't have anybody you can do this assessment on, just plop a bunch of pillows in the bed and talk to the pillows like it was a patient and put your hands where they should be. Again, this is just to try and help you internalize this postpartum assessment. So I'm going to start off cleaning my stethoscope. I've already done my hand hygiene, so I'll do that again, wash my hands. I'm going to come in and introduce myself to the patient. Hello, Noelle, I'm Kathy. I'm going to be your nurse today, and I'm going to be doing a postpartum assessment on you. I'm going to go ahead and clean my stethoscope, so I'm ready to go. And I always start off my assessment by asking how my patient is feeling. How are you feeling today, Noelle? Are you in any pain? Where is she feeling pain? If she had a vaginal delivery, she may just have general muscle aches everywhere. She may have perineal pain from an episiotomy. If she had a C-section, she may have incisional pain. And I can get a lot of information about her psyche just by that initial interaction. Tell me about your baby. Do you have a name for this baby yet? Is the baby feeding well? Those kinds of things will tell me something about her emotional state. So Noelle, I'm going to start off doing your assessment, and it's a little easier for me if we just have Grandma hold this sweet baby. I think you told me baby's name was Charlie. So I'm going to hand off baby to Grandma. Grandma Lisa. Okay, and we'll get started. The first thing I'm going to do is vitals, and you don't actually have to do the vitals, you just have to tell me you're going to do them. So I would take her blood pressure, and I would expect it to be within normal limits unless she had preeclampsia. I'm going to take her pulse and her respirations, and again, I would expect them to be within normal limits. I'm going to take her temperature, an oral temperature, and again, I would expect it to be within normal limits. And I've already asked her about pain. Then I'm going to start my assessment. And when you do a postpartum assessment, the easiest way to think about it is to think going according to your checklist using the acronym BUBBLE-HE. So before I start with my BUBBLE-HE, I'm just going to do everything that involves my stethoscope first. Can you take a nice big deep breath for me, Noelle? Oh, she's very heavy. Can you take another deep breath for me? And I'm going to listen to her heart in the 5 spots that you've learned before in health assessment. Aortic, pulmonic, second pulmonic, tricuspid, and I would come underneath here to listen to the mitral. While I'm down here, I'm going to go ahead and listen to her bowel sounds. Again, just like we've done before in health assessment, starting in the lower right. I'm going to move my stethoscope up here so you can see a little bit better, but you would obviously be underneath her gown. And I would expect her to have active bowel sounds. If she had a C-section, particularly if she had a general anesthetic, I would really want to make sure that she had bowel sounds before I let her drink anything. Okay? Now, Noelle is very heavy and she's not going to sit up for me, but I would have her sit up next and I would listen to her lung sounds on the back. And most pregnant women, or most women that have just had a baby, are healthy. And in general, if I listen to just her base lung sounds and those are clear, the rest of her lung sounds will be clear as well. Okay? So that's her heart, her lungs, her bowel sounds. And the other thing that I'm going to do while she's sitting up, which again I can't do because she's very, very heavy, is do her CVA tenderness. Come over here, Bob. So here comes my trusty stand-in very quickly. Turn this way. Okay. And remember when we do CVA tenderness, does that hurt?
No.
Does that hurt?
No.
Thank you very much. You can sit down. Okay. Now I'm ready to go head to toe. Bubble heat. So if we think about first the B in bubble, that's breasts. And so I'm going to look at her breasts. I'm looking to see if they're soft or they're full, if they're filling or not, if there's any red spots, if there's any cracked or open spots on the nipples. I can ask her how her baby is nursing at this point, if he's latching on well, if she has any pain. Okay? Patients often, and students too, wonder really what does it mean, soft or filling? Well, a soft breast is like yours are right now. And so if you just put your hands up here and palpated, you would feel that this is generally soft tissue. But when the milk starts coming in, even up here high, it feels firm. And definitely on the breast tissue, it feels very firm. And that doesn't usually happen until day 3 or 4. So I would expect them to be soft. There should be no pain with breastfeeding. And so if she's got cracked or bleeding nipples, that would be a concern. If I'm uncomfortable about asking to see her breast at the very beginning of her assessment, I can just ask her some general questions. Noelle, how is breastfeeding going for you? Do you have any pain when the baby latches on? Does the baby swallow? Can you see the jaw movement as the baby nurses? Maybe the next time you're ready to nurse little Charlie, you could call me and I can come and just make sure that he's latched on correctly. And that way I'm doing an assessment of how the baby's feeding at the same time as I'm doing a breast assessment. Okay, so that's B in bubble. Moving down, U, uterus. After the baby delivers, the uterus shrinks considerably and it should be at the level of the umbilicus. And so I want to palpate the uterus right here midline at the belly button to make sure that it's nice and firm. It's really important that I have a hand on the symphysis because if I don't, I can actually send the uterus outside of the body, inside out, which is called a uterus inversion, which is not something we want to experience, okay? And I pulled back the covers, you might notice, and spread her legs a little bit because as I'm palpating and massaging the uterus, I want to look and see if she has any lochia or any clots that come out, okay? So that's the reason that I'm wearing gloves. Okay, so that's B, breasts, U, uterus, then BB, bowel and bladder. I've already listened to her bowel sounds. I know something about her bladder status already because when I massage her uterus right here, if it's right in the middle at the belly button, then her bladder is probably empty. If I felt for her fundus and it was above the umbilicus and deviated over to the right, then her bladder is probably full. And so remember her bladder sits right here. But I can ask her, have you gone to the bathroom lately? When you go to the bathroom, are you peeing into the hat so that I can measure it? I'm going to want to measure how much you pee each for at least 3 visits, 3 times to the bathroom. And again, this is not so much for a regular I&O, but just to make sure that she has full control of the sphincters again. So if she got up to go to the bathroom 3 times and I went in to look and there was only 50 mils in the hat and my uterus was above the umbilicus and slightly deviated to the right, I'm going to think, boy, she's not emptying her bladder all the way. Whereas if every time I go in there to check after she's gone to the bathroom, she's urinated 300, 400, 500 mils, and her uterus is midline and firm, then I feel very confident that she's emptying her bladder. okay? Sometimes it takes us a while to get that feeling back after we've had a baby, particularly if we've had an epidural. And so even though she can pee, she may not sense that her bladder is still full. Okay, so that takes us through B, U, B, B. L is Lochia. So her Lochia, remember, we already looked at a little bit when we were massaging the uterus. And when I look at Lochia, I'm looking at the color, the amount, and the consistency. So think about when you have a period. At the very beginning of your period, the bleeding is dark red. As your period goes on, as you get to day 2 or 3 or 4, it gets lighter and lighter in color till it's finally kind of a yellowish color, and then it's gone. And the same thing happens after we have a baby, only there's more blood. The presence of clots is an abnormal finding. Usually if I see clots, my uterus has been boggy, meaning that when I go to massage it, I can't feel it. And as I massage really hard, then one of those clots pops out. So it's good to get those clots out, because as long as they stay inside, we're going to have trouble, okay? And then the other thing we want to assess is the odor. So color, amount, and odor. It should smell just like a period. It has an earthy smell, just like blood does. If it has a foul odor, then maybe she has an infection. Now, I also like to assess Lochia by having my patient roll away from me. And again, Noelle is very heavy, and she is not going to be able to do that. So try and imagine her rolling away from me so that I'm looking from the back. And the reason I do this is because sometimes we have these quiet bleeders who don't have big gobs of blood here on the bed, but when you roll them over, you'll see that the whole bed linen is saturated with blood, okay? And so this is a way for me to really get a good assessment of what her bleeding is. While I have her on her side, again, imagine she's rolled away from me. I can look from this side here and lift up a buttock and use my pen light to assess the episiotomy and to assess if she has any hemorrhoids, okay? Okay, so breast, uterus, bowel, bladder, Lochia, episiotomy, we just talked about, right? Easier to view it from the back than from the front. You can try and look here, but you're not going to be able to see it very well. It's an incision or a lat that's been repaired like any other incision, so we're going to use our Rita and look at redness, edema, ecchymosis, discharge, and approximation, okay? If she didn't have an episiotomy, maybe she had a C-section, and so I would come up and look at her incision. It should be a low transverse incision, probably with staples on it, and we're going to do the same kind of assessment, okay? Okay, so that's B, U, B, B, L, E. Then we get to the HE, bubble HE. The H stands for Hohensign. And you're probably trying to tell me we don't do Hohensign anymore. We learned that in health assessment. Well, I'm going to tell you that it's still in the OB books, okay? And so what I'd like you to do is think about, why do we do Hohensign, or what were we looking for? We're trying to check for a deep vein thrombosis, right? A DVT. And so the reason that the health assessment book tells us not to do a Hohensign is that we could actually dislodge a clot, which is actually very unlikely to happen, especially in a healthy person, okay? But for Hohensign, instead of actually doing Hohensign, and I'm just going to take my gloves off here, we can just feel for calf tenderness and for heat, okay? And that's enough of an assessment for that piece of it. And while I'm down here, I want to check for edema and see if I have any pitting edema. And then I want to do reflexes. Now again, Noelle's not on, so she's not going to have any reflexes. But remember, we use our reflex hammer or our hand. We find the cleft right here. She has to be dead weight. I'm going to do reflexes. Here we go, +2, okay? When I know she's relaxed and I have normal reflexes, then I'm going to come down and dorsiflex her foot for clonus, and there should be no clonus. If we had clonus, we would see beats. And so instead of a smooth dorsiflexion, we would see bump, 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 okay? So she had 2+ reflexes and no clonus. The last part of my acronym of bubble HE, that E is emotions. How is her psyche? Which I've been assessing throughout my interaction with her, and I did when I first walked in the door, okay? What's normal after somebody has a baby is for the focus to shift from what's happening to me and how I feel to what's happening to my baby, right? And to start interacting with my baby. And so those are the kinds of emotions that we're looking for. A mom that's interested in what's going on with her baby, a mom who wants to hold her baby, a mom who's excited about her baby and wants the father of the baby or the other family members in. We would be very concerned if the mother never made eye contact with the baby, if she just answered in a monotone voice and didn't look at the baby. That would be concerning to us. Sometimes new moms cry, and they cry a lot for no apparent reason. And that's really not concerning. That's a normal thing because of the hormones, again, adjusting back and forth. And they may say, I don't even know why I'm crying. I'm just so happy. And again, that's fine. And we can reassure that those things are fine. But Noelle, when you get home 2 or 3 weeks down the road, if you ever get to a point where you feel like you couldn't take care of your baby, like you were so tired or you were feeling so down that you didn't even want to get out of bed or take a shower or bathe your baby, that would be abnormal and might indicate postpartum depression, and we would like you to call your healthcare provider. Okay, that concludes my postpartum assessment. Let me look at my card and make sure I didn't forget anything. And sure enough, I did forget something. The same 3 things that I forget every time I do this. Okay, so I forgot to note, although I would have noticed them as I was going on, that there are skin changes that are normal with pregnancy. The first one is what we call the mask of pregnancy, this colasma of pregnancy. Not everybody has it, it usually fades. The second skin change is the linea nigra, which is a line from the belly button going down to the symphysis. It also fades. And then many pregnant women and new moms have stretch marks, striae. So they might be here, they might be here on her belly, they might be here on her legs. They could be silver colored or white colored or red colored. We're just going to note that they're there. Okay? They do generally fade. Nothing is ever as it was before, but the body has an amazing way to recover. And then the final couple of things that I forgot to ask her was if she was sweating at all. Noelle, have you been noticing that you've been perspiring some, maybe especially at night? Remember we talked about how we have that huge shift in fluids, and we have that increased blood flow. We increase our amount of blood by about 40%. So now we have to get rid of all that. Additionally, in labor, many women have an IV. They get IV fluids. And she might have gotten a lot of IV fluids if she had an epidural. So now in the course of 1 to 3 days, she's going to get rid of all of that. And so those legs that were really puffy, tomorrow she's going to be able to see her ankles. Okay? And so she's going to get rid of it by peeing it out and also by perspiring. So if she woke up in the middle of the night and her sheets were all wet, as long as she doesn't have a temperature, she doesn't have an infection. She's just trying to get rid of all that extra fluid. Okay? And then the last piece of it, Noelle, is just to talk about your activity and your diet. So I want you to try and drink plenty of liquids. You're nursing little Charlie, so we want to make sure you get 300 to 500 calories a day extra so that you can keep your milk supply up. And when you think about activity, as long as you're moving around okay and you've got full strength of your legs, you're free to do pretty much anything. But our advice is to not pick up anything heavier than the baby. And if you'll stick to that, as the baby grows, your muscles will get stronger and kind of go back together a little bit, and you'll be in good shape. Okay, so sad to say, that means when you get home, no vacuuming, no carrying big, huge loads of laundry. That's what your visitors are there to do for you. Okay, that's it.